So I will focus on the CLL microenvironment, its role in pathogenesis, modeling, and brief glimpse on maybe how we can target it. So the CLL microenvironment, and the myeloma people I think will tell me, well, that's the same in myeloma. It's a complex mixture of things. And a lot of work in CLL really has been done with the peripheral blood cells that are taken in vitro, and they will die unless they're supported with some surrogate of microenvironment interactions. And over the last 20 years or so, a number of molecules and pathways have been identified that can actually support these CLL cells in vitro. And the list is quite daunting and ranges from chemokines, cytokines, immune receptor signaling, just interaction with extracellular matrix components to Wnt pathway. And if we take all of them to be equally important, I think we end up with a tumor that is really totally opportunistic, that can survive and feed on whatever it encounters. But then the question is a little bit, what is the tumor actually really encountering in vivo? And are there any pathways that stick out as maybe more important than others? An attempt to try and see if in vivo there's something that stands out. We asked 24 treatment-naive patients to give us concurrent samples from peripheral blood, bone marrow, and in 17 we also could have a lymph node. We then generated single-cell suspensions from all these tissues and purified the CLL cells by CD19 selection and arrayed them on Affymetrix arrays. So we're comparing pure tumor from different anatomic compartments, not different tissues. And the first impression was, okay, location really matters. As we know, we're in Whistler. Location matters. So the lymph node appeared to dominate these differences between the different compartments, but in general, the gene expression complement of cells in different anatomic sites differs within the same patient. And here are the differences shown for the lymph node. These are in columns the samples matched for lymph node and peripheral blood from the same patient, and in the rows the genes. And we see that about 200 genes were significantly overexpressed in CLL cells isolated out of the lymph node. We submitted this for analysis to gene set enrichment analysis and identified the key pathways behind these gene expression differences as B-cell receptor signaling, NF-kappa B activation, calcineurin NFAT signaling, which is downstream of the B-cell receptor, and then also found genes that are regulated either by MYC or genes that are well known to be overexpressed in proliferating cells. So what the gene expression complement then tells us is in the lymph node, we have activation of the B-cell receptor pathway, and we have proliferating cells. Just very briefly to show you the validation for the B-cell receptor pathway. So we took cells from peripheral blood and lymph node and did phosphoflow, and we see that SYK kinase, one of the upstream kinases in the BCR, is activated in the lymph node, but hardly so in the peripheral blood. And we also generated a gene expression signature in CLL cells that were activated through the B-cell receptor to validate that these target genes we call BCR regulated are really the BCR target genes. So this actually fits very well with another line of 20 years of investigation that characterizes the CLL really as a malignancy of autoreactive B-cell. And I think Federico Caligari-Scapio was the first one to really put this, at least put it in a title of a review. So CLL as a malignancy of an autoreactive B-cell that's supported by the analysis of the B-cell receptor repertoire, which is skewed to certain specificities, that the B-cell receptor can activate the cells and support their survival in vitro has been well appreciated. These B-cell receptors often recognize autoantigens and are maybe kind of polyvalently activated by autoantigens in vivo. And interestingly, also this BCR reactivity assessed in vitro correlates or can predict the outcome of the patients. So altogether then, no definitive evidence, but a lot of correlative circumstantial evidence pointing to the B-cell receptor as the pathway that sticks out. But I would like to emphasize that it only sticks out. I think all of this is happening in the context. The lymph node, the location matters. And why does it matter? Probably because there are additional cell types that either provide co-stimulatory molecules or provide antigen presentation to the CLL cells. In particular, T cells, again, work from Federico, who showed very nicely that the CLL cells and the T cells organize each other in the lymph node into proliferation centers. And that probably some elements of T cells are necessary for full proliferation. And then work from Tom Kipp's group and from Jan Burger has shown that macrophages and also, at least in vitro, play a very prominent role. I think it remains to be seen how important their role is in vivo. So where can we investigate all this? So one approach we've tried to do to model this is to use a system that Nick Urasi's group has reinvigorated, and that's the injection of CLL cells into NSG mice. And so what we do is we inject peripheral blood into NSG mice, so peripheral blood from CLL patients. So there are T cells, there may be also some monocytes, they're definitely the CLL cells. And what we then see is we get here, that's peripheral blood data. We initially have circulating CLL cells that by 3 to 4 weeks have pretty much disappeared from the peripheral blood, but we find them, especially in the spleen, to a much lesser degree in the bone marrow. So this model then basically, we have cells in the peripheral blood, we have cells in the spleen, and in the spleen they organize into nodules. Here CD20 staining identifies these CLL nodules. So now we could ask the question whether these cells in the mouse spleen, do they resemble the cells in the human lymph node? And our reference is the human blood. So we have patients that gave us blood that we injected into mice. We get these cells out of the spleen. And at the same time, we have this patient's lymph node. And so in subsequent slides, I will compare from the same patient cells in the mouse, cells in the lymph node, and cells in the peripheral blood. So very quickly, this is actually a comparison now from mouse blood to mouse spleen. And we see the same thing we've seen previously in the patients, that in the microenvironment, these cells are activated. They express CD38, CD69, and have a downregulation of CXCR4. So this in the mice, shown here in the white bars, is the same pattern we've seen in the patients. So in the microenvironment, cells are activated and they downregulate CXCR4. These CLL cells in the mice proliferate. So this is a CFSC dilution curve. So this is the input, and this is the dilution of the CFSC over time, indicating proliferation. And we actually estimate the proliferation rate in the mice to be about 1% of the clone per day. This is very close to what's been measured in patients using heavy water. In patients, you see different patterns of how cells organize. In some CLLs, you get proliferation centers, so Ki67 staining is only in the proliferation centers. In others, you have this confluent, more diffuse pattern. And you definitely see that in the lymph node, you get Ki67 expression, which is not present usually in blood cells. So we see very similar patterns in these mice. So this is CD20 expression. This is a CLL nodule in the mouse spleen. It is admixed with human T cells. So these cells are in a partially humanized environment. And there is Ki67 staining, which you'll actually notice it's a little stronger in the areas with a lot of T cells. The T cells also proliferate in these mice, and they actually proliferate somewhat faster than the CLL. So when we do flow and gate on the CLL cells, we see that there is increased Ki67 expression in the spleen. Again, showing us that also in the mice, location matters. In the spleen, you have the activation. And so now we want to compare how this is a validation also using gene expression that basically shows now that the proliferation rate in the mouse spleen is very similar to that in the human lymph node, using expression of genes that are upregulated in proliferating cells. And so then, if you want to use this model to study targeted agents, we want to be sure that we have similar pathways activated. And we did this by looking at BCR and NF-kappa B target genes. And now here we're comparing the cells out of the mouse spleen, out of the human lymph node, in reference to their isogenic human peripheral blood cells. And you see that there is an upregulation of these target genes in both tissues, mouse and human. And if we combine this into BCR or NF-kappa B target scores, we see that both lymph node and mouse spleen support the activation of these pathways to about the same degree. And we validate this here by doing phosphoflow for BTK. So we can show that the BCR pathway is activated on target gene expression and on signaling molecules. So now we went on and used ibrutinib in these mice to investigate some translational endpoints. But what I want to conclude on is really targeting these cells in the microenvironment. I think it's building also a little bit on what Jenny already showed. So these inhibitors of BCR signaling, they happen to do one very particular thing. They lead to treatment-induced lymphocytosis. And this is lymphocytosis is almost immediate. This is day 2, that's after 1 day of ibrutinib. 1 dose of ibrutinib leads to a 50% increase in the lymphocyte count, which then over time gradually declines. So an immediate effect that we think is primarily driven by inhibition of adhesion. This is an adhesion assay. The green dots are CLL cells adhering to fibronectin. When we take from the same patient the cells on day 28, after 4 weeks on ibrutinib, these cells are unable to adhere to fibronectin. So here we have a drug or a class of drugs that in part really disrupts the ability of the cells to adhere to their preferred locations. But even after 2 months or even after 6 months, you still have CLL cells in tissues. Now, assessing lymph node after 2 or 6 months is virtually impossible because most patients, the lymph nodes are so small that you can't reasonably biopsy them. But we can look at bone marrow. So there's residual disease in the bone marrow. And this disease is actually quiescent. It's inactivated. Here, this is phospho-ERK in cells in the bone marrow, pre-treatment. And this is after 2 months when we do the rebiopsies. You see phospho-ERK is greatly decreased. Expression of the activation marker, CD86, is greatly decreased. And proliferation, as shown here for Ki67, is greatly decreased. So this residual disease 2 months into treatment that is still in the tissue microenvironment, at least in the bone marrow, is quiescent. And another, going back to the T cells in the lymph node, another insight really from the NSG model, this is data from Nick Urazi's group, was that the CLL proliferation in the mice depends on the presence of T cells. So here are a few mice that did not have T cells or not a high number of T cells, and they had very low CLL cell proliferation, whereas mice with more T cell engraftment had better CLL cell proliferation. So that was the observation from the Urazi group, and then they wondered whether abolishing the T cell component with OKT3 would inhibit CLL cell proliferation. And here indeed, in white is the CLL cell proliferation, and the brown is after applying an anti-CD3 antibody. You can block this proliferation of the CLL cells. So in the NSG mice, the CLL proliferation does depend on the presence of T cells. And as a side note, fludarabine, our old major drug, is a very toxic drug for T cells. So we've always been treating CLL, the B cell component, and the T cell component. Okay, I would like to acknowledge our patients really for volunteering a lot of samples to make these studies possible. Mohammed is leading the clinical trial and Sarah the translational analysis. Thank you.